So when we want to talk about reflux, we have to see how our body is tuned to prevent reflux first. As you know, there is a function, the reflux is prevented by the function of the gastroesophageal junction and the geometry of gastroesophageal junction. This geometry is maintained by intra-abdominal portion of the esophagus. A section of your esophagus is in the high pressure abdominal zone, and this maintained in this location by esophageal ligaments. Also with the acute angle of His, the angle that's maintained between the cardia and the fundus of the stomach and the esophagus. Angle of His is very important, and it is maintained by the contraction of the sling muscle fibers against clasp fibers of the stomach, and also turning of the fibers of the right crus right at the GE junction, anchoring it to the vertebra. When everything is in order, when we do endoscopy, you will see this appearance here, a fold of tissue that comes and wraps around the scope and prevents reflux. This is endoscopically known as flap valve. When you have a normal geometry of the stomach after eating, let me adjust this projector. Okay. So after eating, you will have the fundus of the stomach ballooning up and transmitting the pressure from the intragastric to the flap valve and closing the flap valve against the lesser curvature of the stomach. In this function of the flap valve, in addition to the work of the lower esophageal sphincter, will prevent reflux. Now, what happens that people develop reflux? Part of it is because of the loss of geometry. So you have the loss of intra-abdominal esophagus because of that phrenoesophageal ligament become attenuated due to wear and tear with aging, stress of swallow. You will have the widening of the hiatus around the GE junction because the stomach moves up and stays at the level of the diaphragm, increasing the size of the hiatus. And you have the widening of the angle of His. So with the clasp fibers and sling fibers are the only last resort option to maintain the anatomy, normal anatomy of the stomach. They fail, and you will have the development of a funnel-shaped stomach as opposed to a normal stomach with the acute angle of His. At this point, when endoscopically we look at, there is no flap valve. The flap valve disappears. And this is the beginning of a cascade of development of sliding hernia. You have a funnel-shaped stomach that very easily slides up to the mediastinum, and you will have a sliding hernia form. Over time, the transmural fibrosis of the hernia, because of the esophagitis and chronic friction, makes the sliding hernia to become non-reducible. So this hernia does not come back to its original position. Stomach doesn't go all the way below the diaphragm. And over time, you will see development of a very tortuous and windy esophagus that we sometimes describe as a presbyesophagus. People start having problem with swallowing because the stomach basically moves to the chest, esophagus becomes all tortuous, and people having problem with swallowing now. Not only GERD, but difficulty with dysphagia. So, in the present, after the geometry of the stomach just becomes distorted, after eating, the gastric pressure directly transmits to the esophagus, and the lower esophageal sphincter remains as the only layer of defense against reflux, and usually that will fail too. Currently in the United States, there are 20 million people on PPIs because of acid reflux. And the good news is almost 60 to 70% of them are happy with their treatment option. But there is 30 to 40% of people that are in what I call unhappy zone. And why they are unhappy is because of different reasons. Some of them are not responding to PPIs, some of them are having side effects from PPIs, some of them are having lots of breakthrough. They take it in the morning and by early afternoon they become symptomatic. And I'm sure all of you encountered this, lots of people are afraid of long-term damages and adverse reactions associated with these medications. As you know, there are lots of publications coming out, and this is not just the media, this is also our literature, and also FDA putting warnings about long-term use of PPIs. And although maybe some of them have been taken out of context and put in media and overblown, but there are some serious risks associated with these medications, which leads into FDA putting some restriction and warnings about the chronic use of these medications. On the other hand, we have to see how these medications are working. So if 30 to 40% of people are unhappy with medications because their symptoms are not controlled, are the PPIs doing their job as far as preventing some of the neoplastic problems that can happen as a result of chronic reflux, such as Barrett's? We know that Barrett's is directly corresponding to the amount of years that you have reflux. So if you're having reflux for just few years, your chance of having Barrett's is low, but when you have many years of acid reflux, the chance of having Barrett's on endoscopy is higher. And that's why that's one of our recommendations when people becoming dependent on PPIs or having GERD for many years, they need to have an endoscopy for evaluation of Barrett's. And also we know that over years, Barrett's constantly is improving despite of use of PPIs. But does it translate to more cancer? Yes, in fact. Esophageal cancer currently is the fastest growing cancer in the United States, more than pancreas, more than colon, more than breast, or prostate. And we know the kind of esophageal cancer that now we get is adenocarcinoma, which is directly as a result of reflux. 20 years ago, the most common cause of esophageal cancer was squamous cell carcinoma, which was because people were drinking and smoking. So patients changed their habits, they are less drinking and they're having a better lifestyle, and the squamous cancer is constantly decreasing. But with the introduction of PPIs and less of mechanical treatments to deal with the underlying problem of a reflux, we have a constant increase of adenocarcinoma to a degree that makes the esophageal cancer the fastest growing cancer now in the United States. So I hope that you can appreciate that there is a mechanical component to this disease. There is a disease progression that starts with losing the shape of the stomach, forming of hiatal hernia, and worsening of reflux. And the biggest problem with PPIs is that PPIs do not stop the disease progress. So you are putting a Band-Aid, controlling patient's symptoms, but really you're not stopping the progression of the disease in these patients. Over the past century, the convergence of anatomic hernia repair surgery with physiologic surgery resulted in multiple surgical options to treat reflux and resurrect the gastroesophageal junction. Three fundamental principles for successful anti-reflux surgery includes creation of artificial flap valve via fundoplication, restoration of the angle of His, and closure of the hiatus. Over the past century, three surgeries did withstood this test of time, and the most commonly used of them is gastroplication, described by Rudolf Nissen, or what we commonly call as Nissen fundoplication. So in Nissen fundoplication is a transabdominal surgery that a 360-degree flap valve will be created by plication of the fundus around the esophagus and after closure of the hiatus. The second most common surgery used, described by Lucius Hill, is posterior gastroplasty. This is another transabdominal surgery that is a very physiologic, and during this surgery, the GE junction will be plicated to the periaortic fascia, and angle of His will be restored. The third surgery, described by Ronald Belsey, is the Belsey Mark IV fundoplication. This is a transthoracic surgery, and during this surgery, a 240-degree anterior flap valve was created by plication of the stomach to the esophagus, which restore the angle of His and after closure of the hiatus. There are some problems with Mark Belsey fundoplication, and it is a transthoracic, so it's invasive, requires a tracheotomy and left lung collapse to access the esophagus and do the fundoplication. But this is until now, and with introduction of transoral fundoplication using MUSE system. So endoscopic anterior fundoplasty using Medigus ultrasonic surgical endostapler became available in this country in 2014, got the FDA approval. MUSE is a transoral surgical flexible endostapler that will be introduced through the mouth and plicate the gastric fundus to the esophagus with the help of a camera and an ultrasonic length finder. The process starts by bringing the stomach back to the abdominal cavity with the help of positive PEEP and intragastric insufflation. After the hernia is reduced and the stomach is back to the abdomen, the fundus of the stomach will be reapproximated next to the esophagus with the help of the bending section of the scope. And at this point, the ultrasound wave is used to measure the distance between the stomach and the esophagus. And when this area is less than 3 millimeters in size, 4 millimeter titanium surgical staples will be applied to create a fundoplication. This is similar to Mark Belsey fundoplication. At least 3 areas of the gastric fundus will be plicated to the esophagus, which results in the widest flap valve anatomically possible. MUSE is not the only endoscopic treatment available for us for treating GERD. Actually, there are many of them that came and went out of the market. The first one that was introduced was Stretta, that was FDA approved in 2000. Second one that is still available is TIF, introduced in 2006, and the MUSE is the latest one. So let's take a look at what we can do nowadays with available endoscopic means that we have. We are able to reestablish the intra-abdominal portion of the esophagus, create a flap valve, resurrect the angle of His, and reduce the compliance of the cardia to compensate for the widening hiatus. With MUSE system, we can create a flap valve after restoration of intra-abdominal esophagus and correcting the angle of His. With TIF, or transoral incisionless fundoplasty, a wide area flap valve can be created, and also intra-abdominal portion of the esophagus can be maintained. And with the Stretta, with the help of radio frequency waves, you're placing electrodes in the GE junction that remodel the esophageal sphincter and also decrease the compliance of the cardia and the GE junction to prevent reflux. So what I hope that you take from this talk is that PPIs, although are still the standard of care and the first option in treatments are not as innocent as once we thought. And there are people that are really having symptoms and unhappy or concerned about their symptoms. And in 2016, we have endoscopic treatments that can offer them even if they do not want to undergo a surgical intervention for treating their GERD symptoms. Also, I want to let you know that selection of each of these patients really is based on what is their current geometry of the GE junction. I see these patients that refer to me, and one of the things that we are doing right now at the national level is trying to come up with a criteria to how to classify the different GE junctions and see which patient would benefit from which endoscopic treatment and to increase and improve our patient selection, and which patients are the ones that directly needs to go to surgery and would not benefit from endoscopic treatment. With that being said, about endoscopic anti-reflux therapy, I have to say this is for sure not the end. This is not even the beginning of the end, but I think this is perhaps the end of beginning. And this is a very exciting time for us.